Welcome back to my channel. My name is Marcin Wojnowski. I am a neuroscientist and a first-year medical student, and today we'll be reacting to Grey's Anatomy and evaluating how medically accurate this TV series is. So let's get started.
Hi, I'm Isabel Stevens, but everyone calls me Izzy.
I have 5 rules. Memorize them. Rule number 1, don't bother sucking up. I already hate you. That's not going to change.
So as far as I remember, she's Dr. Bailey. She's general consultant. So I may like her as a character in this TV series, but from the medical point of view, her attitude is awful. So one of the challenges as a doctor is being able to teach efficiently, being able to pass your knowledge onto somebody else. So the thing she's showing is quite bad because, first of all, if I was one of them, I would be quite afraid even to talk to her. Because why would I? I would like to, for example, learn something, but I would be afraid of being judged. I would be afraid of, being embarrassed in front of everyone. So that's not the point. Maybe it used to be like this, 2, 3, or 4 decades ago. But right now, I'm quite happy with this. Right now, at least in the UK, we actually respect each other because everybody had to start from something. Nobody was born great surgeon. Nobody was born genius. Everybody had to work through to become one of the best, or to become geniuses, or to become Nobel Prizes winners, whatever. So you must start from somewhere. So no, that's quite bad attitude. But we've just actually started.
Trauma protocol, phone list, pagers. Nurses will page you. You answer every page at a run. A run, that's rule number 2. Your first shift starts now and lasts 48 hours.
Multiple studies spanning different countries have shown that working traditional 30+ hours can have devastating effect not only on physicians, but also for patient care and patient safety. So no, working long hours is not good, is outdated, and should be scrubbed as soon as possible.
Interns, grunts, nobodies, bottom of the surgical food chain. You run labs, write orders, work every second night until you drop, and don't complain.
Well, the ox forgot it was once a calf.
What do we got?
Katie Bryce, 15-year-old female, new onset seizures, intermittent for the past week. IV lost en route, started grand mal seizing as we descended.
So here we've got a patient with intermittent new onset of seizures. Intermittent means that she had seizures in the past week at various times. And seizures themselves mean that there is some uncontrolled, unexplained firing of neurons within the brain. Because normally neurons fire in a well orchestrated and well organized way. Meaning that you can make movements, you can have thoughts, and all of the processes that happen in your brain, they just happen without any disruption. So seizures is also a red flag because it's one of the first signs of a brain tumor. Because normally, John, let's take it, John. So we've got the John, we are opening his cranium. And as you can see, the cranium is a closed box. So whatever grows within the brain must take space of something else. But more importantly, if it grows, it disrupts these neurons that were connected. And it disrupts these neurons that were firing in a controlled way. Now they are hyper excited and they started firing in an uncontrolled way. As a result, you have seizures. So that's why it's a red flag, especially in a young patient without any prior history. They also said that the IV was lost en route. Yeah, can happen.
All right, get on her side. Izzy, 10 milligrams diazepam IM.
All right, also Dr. Bailey asked to position patient on her side. The reason is very simple. Seizures usually trigger saliva, vomit, or blood from the tongue biting. So the main point is to prevent any aspiration of either of these 3 things. So you just position the patient, and if the patient starts vomiting, actually you can position the head upwards and the vomits can just come out from the patient. And also, the second reason is to keep the airway open So that's the reason why. Also, Dr. Bailey says to administer diazepam 10 milligrams IM. IM means intramuscularly, so into the muscle. So, and we can see that it just works instantaneously. No, it doesn't work this way. So diazepam, I don't know why they decided to go with diazepam. So the onset of diazepam given intramuscularly is 15 to 30 minutes. So we wouldn't see any instantaneous action of diazepam. I think the first line for such episode of seizures is midazolam. So midazolam given intramuscularly would work within 5 to 10 minutes. But anyway, they just decided to go with diazepam. So let's keep it.
No, the white lead is on the right. Righty, whitey, smoke over fire.
So righty, whitey, smoke over fire. So this is the mnemonic. So medical students, many of them, they prefer learning some stuff through mnemonics. And it can be useful. I'm not a big fan of it. I like a few of them, but I don't heavily rely on them to remember some stuff. So what it basically means, this is the mnemonic for the ECG lead placement. So righty, whitey, so right arm, white lead. Smoke, black, so black lead on the left arm. Over fire, so fire is red, so it's going to the left leg, and green is going on the right leg, and this is a grand lead. So in the UK, we use different color schemes for ECG placement and different mnemonic, obviously. And I quite like this one, although. And the one I like is right your green bike. So right, so red is going on the right arm. So yellow is going on the left arm. Green is going on the left leg. Bike, black is going on the right leg. So this is basically mnemonic. This is what it is.
A large bore IV, don't let the blood hemolyze. Let's go.
Dr. Bailey says to use the large bore IV, meaning that she's asking to place a large diameter venthone into the vein. The reason is quite simple. They want to send blood to the lab. And if they, for example, put small diameter venthone into the vein, they would risk that the blood they're about to drain will be damaged, because you need to forcefully drain the blood out. So if there is a too small diameter, they risk hemolysis, as she says. Hemolysis basically means the destruction or damage of red blood cells. Why is it important? Because in the lab, they want to measure the levels of potassium, chloride, sodium, and bicarbonate from plasma. And we need to take into account that in the red blood cells, there is more level of potassium than in plasma. Typical level of potassium inside the red blood cells is between 100 and 120 millimoles per liter, unlike outside the red blood cells. So in plasma, it is between 3.5 up to 5 millimeters per liter. So as you can imagine, if something leaks out of the red blood cells and mix with the content in plasma, it can produce pseudo results. So we don't want to see it. Therefore, it's quite important when you're taking out the blood from the vein to take it using with a larger diameter venthone, and to take it with care. Do not rush.
12.
Magic diazepam.
We had a wet fish on dry land.
Absolutely, Dr. Burke.
Dr. Bailey, let's shotgun her.
That means every test in the book, CT, CBC, Chem 7, tox screen.
Okay, CT is a good call because we don't know why she's got seizures. There's no prior history, so we want to rule out any mass or brain tumor. CT, I mean, for the brain tumors, preferable tool is MRI because it's way better for the soft tissues. But in such case, it's quicker to do CT and see actually what we're dealing with. And then after she says Chem 7, so in the US, I think it's a biochemistry 7, meaning 7 things are being checked or measured in the blood. And these things are sodium, potassium, chloride, carbonate, blood, urea, nitrogen, creatinine, and glucose, because we also don't know if she's diabetic. So hypoglycemia can cause seizures as well, especially in diabetics. The reason is very simple. Neurons in the brain heavily rely on glucose. They cannot store glycogen like the liver or the muscle cells. So they constantly need to be fueled with glucose. And that's actually, they have specialized vesicles that do this job all the time. But that's the point. If we are deprived of glucose for the prolonged time, then it can lead to the disruption. So the entire machinery is just collapsing, and as a result, you just get seizures. So that's why we want to see what we are dealing with. And the third thing she's saying is tox. So tox is just toxicology. So we want to obviously make sure that she didn't take any recreational drugs or whatever. So basically, a good call actually. Yeah.
Christina, you're on labs. George, patient workups. Meredith, get Katie for a CT. She's your responsibility now.
She looks devastated. Is she my responsibility?
Wait, what about me?
Honey, you get to do rectal exams.
All right, so she wasn't thrilled about doing these rectal examinations. Okay, fair enough. Not everyone would be happy, and maybe this is not the most pleasant thing to do. But it's actually a great learning opportunity, because you need to know how to approach the patient. You need to know how to respect dignity, and you need to know how to show professionalism. So these things are as important as the technical skills. So I wouldn't be that sad about it. Obviously, I wouldn't want to do it all the time, but yeah, it's always a good thing to learn.
What are you doing here?
Katie Bryce's labs came out clear. There's nothing in the results that explain her seizures. I just thought you want to know.
All right, so we've got our blood results, which are clear. That's quite good, because we can rule out hypoglycemia. Hypo means low glycemia glucose. Hypokalemia, low kalemia potassium, and hyponatremia, low natremia sodium, all of which could potentially trigger seizures. So what we've got left to see is CT scan to rule out any brain tumor or any masses, because it doesn't have to be brain tumor, to rule out hemorrhage stroke, because if there is any bleeding within the brain, we would see it as a bright white thing on the scan. And also potentially ischemic stroke, but not early on, because once you have a blocked artery, you wouldn't see an immediate effect. You need to wait, because this blocked artery initially would lead to necrosis and edema in any brain area. So you could see if there was ischemic stroke, but not in early on. We would actually see it like after 12 and more hours. So yeah, that's what we're waiting for. Let's see.
I heard every year the attending on call picks the best intern and lets them perform a procedure during the first shift.
So wait, what? So you just graduated from the medical school, and even if you want to be a surgeon so badly, you really need to have an experience. You have to go to the operating room or to a theater, and you have to keep seeing all these operations. You have to keep asking questions. You have to scrap once to see how it looks like. You have to try from very small things. So the idea that the best intern is chosen to perform a solo operation is just outraging. Totally pointless.
I'm just saying it's what I heard.
Go away. Now.
The ox forgot it was once a cow.
You're lost.
I'm not lost. How are you feeling?
So it seems like those are only people in this hospital who do everything. So from taking patients for the scans and for transporting them back or from the ward. In reality, you have different folks responsible for different tasks, including transporting patients from point A to point B. Like in this case, this is how it looks like. So we all work in a huge multidisciplinary team, and that's how it's supposed to look like. Imagine that if you had only one group of people who does everything, how many mistakes you would do. So you can't do that. So no, that's not reality. This is just Hollywood show. what this angle is. Anyway, so let's say that you don't know how to do it. Happens. But you should ask for help. That's the other thing of being a physician. You should know your limits. And if you don't know how to do something, the thing you're going to do is to find a person who knows how to do it and who can show you how to do it, instead of putting patient at a higher risk of stress and probably damage vessels. That's not how it's supposed to work.
Out. Out.
So instead of standing behind like a pseudo boss, he should have asked if he needs help, because he was seeing him struggling all the time. So this is one of the hardest part as well, being a leader. So being a leader doesn't mean to showing superior all the time. Being a leader also mean to teach and knowing how to teach. So that's what it's supposed to do. And he's saying out doesn't mean out. He's not a dog. Everything for drama. But no, that's not what would happen in real life. So before graduation, you're actually being taught of how to put benzone into a vein many times. And even if you're a student, you're also performing such tasks, because after graduation, there's foundation skills you should have already, and then you just keep practicing. This is the reality. Here he's just shown like he would have never done it in his life. So yeah, that's quite wrong.
Bet you missed a lot when you first started out.
Bet you missed a lot when you first started out is actually true. Yeah, everybody missed a lot when they first started out. That's actually true. That's how you learn. You have to make mistakes. And if you don't make mistakes, you actually can't learn. This is a principle of learning. So he's actually right here.
George O'Malley,
Me?
you'll scrub in for an appendectomy this afternoon. Congratulations. Enjoy.
So apart from the fact that this is the most dumbest idea that anyone could come up with, let's see how real it is. And the reality is that it wouldn't have happened, simply because he said that he's going to do appendectomy. So this is an elective appendectomy, not emergency one. So if you have an elective operation, any kind of operation, you have a surgeon who's an expert or a consultant in any specialty. You have anesthetist, and you have theater team, and you have the ward team. So a patient is being seen by a surgeon. A patient is being seen by an anesthetist. The patient is being seen, obviously, and taken care of by nurses on the ward. And then all this information is placed on the list. And before patient is getting to the theater or to the operating room, we have a brief, and we have a surgeon consultant who is responsible for the entire operation, is giving a brief. He's telling anything that is important about the patient, any instruments he needs, and actually everything is being discussed before patient actually appears in the theater. So that's the first thing. Second, Dr. Berg in this TV series is a cardiothoracic surgeon, not a general surgeon. So how come a cardiothoracic surgeon performing an appendectomy? How come? Like, imagine that you have something with your heart, or you need to have a valve replacement, and instead of having a cardiothoracic surgeon, a general surgeon is coming to you and says, "Oh, actually, I'm going to do it because I had seen it 20 odd years ago." No, it's not. That's not true. That's a fiction.
They gave her a sedative for the CT scan, so she's a little groggy.
One of the reasons why she might have been given sedatives was the fact to prevent any seizures, and probably she was given lorazepam, midazolam, or this magic diazepam in this movie. And yes, and after such sedatives, your body can react in a way that you can be groggy.
Well, you know what? I'm not the doctor. I'm a doctor, but I'm not Katie's doctor, so I'll go get him for you.
Yeah, it was actually a good reaction because it wasn't her patient. The patient was being looked after by somebody else, and this is how you're supposed to deal with such situation. So yeah, a little bit more confidence would be great, but yeah, it comes with time and experience.
Okay, O'Malley, let's see what you can do.
What the hell is he doing there? Like, he's not a general surgeon. So why?
More pressure. The human flesh is a tough shell. Dig in. Scalpel.
So first of all, this is a science fiction because he had never performed operation before. Second of all, Dr. Berg is not a general consultant. So such situation would never take place in the real world. So in the real world, the point is that you're applying for specialty training, and if it's a surgery, for example, like a general surgery, let's just say you're just applying for the program, you're assigned to a consultant, and step by step you're just getting an experience, and that's how it's supposed to look like. And appendectomy is not an easy operation. I know that it's perceived as something easy that everybody can perform, but that's not true. Every single patient is different, and every single operation, any intervention carry some risk, and you have to take this into account because you're taking responsibility for somebody's life, and you can't be just reckless. So that's how it looks like in the real world, not something like whatever it is.
What do you need?
Mr. Jones has chunky veins and he really needs antibiotics. I should start a central line.
So start one.
All right, so another absurd situation. Anyway, so central line is quite important. So there are three main places where you can insert central line. It is internal jugular vein, subclavian vein, and femoral vein at the leg. The main point is that all of them eventually will reach the right atrium. The internal jugular vein and subclavian vein reach the right atrium through superior vena cava, and femoral vein indirectly reach inferior vena cava. But the point is that all of them reach the right atrium. So the vein carries deoxygenated blood, and since veins drain the oxygenated blood from the circulation, it means that the drugs that are being provided to a patient reach the circulation way quicker. The other reason why central lines are inserted is because there are certain drugs that cannot be given through the smaller diameter veins simply because they can be too irritant or too toxic for small diameter veins. And the third thing is that you can attach and multiply lines to one central line. And the fourth thing is that they are long lasting. So that's the reason. But the point is that, again, she graduated. So she had no clue how to do it because this is something they don't teach you because it's too dangerous. As you can imagine, the internal jugular vein, you're just actually using the ultrasound to do it. And usually the internal jugular vein central line is being performed by anesthetist or anesthetist registrar under direct supervision of anesthetist consultant, simply because it's too dangerous to do it by your own. So yeah, again, Hollywood science fiction. It looks like subclavian vein. There you go.
Next time you wake me, he said it'll be so close to dead, there's a tag on his cup.
Me, darling.
Here, go out here. Well, they're here.
4B's got post-op pneumonia. Let's start antibiotics.
Are you sure that's the right diagnosis?
Well, I don't know. I'm only an intern. Here's an idea. Why don't you go spend 4 years in med school and then let me know if it's the right diagnosis? She's short of breath. She's got fever. She's post-op. Start the antibiotics.
So how does he know it's post-op pneumonia? Patient is breathless, meaning that patient has a difficulty breathe in air. So it's like and it can be caused by anxiety, for example, or it can be caused by pneumonia, but it can be caused by any other thing. So he must have evaluated what is going on with the patient, and he didn't do it at all, because pneumonia can be caused by a plethora of different bacteria like gram-negative, gram-positive, atypical, fungi, protozoa, viruses. You have to see what is going on. You have to look at the X-ray to see if there is any consolidation. You have to look at CT scans to see if something had been missed at X-ray. and he didn't do it. So you're just not giving empirical antibiotics. Empirical means that you're suspicious to some pathogen that causes pneumonia. I mean to bacteria, and then you're just giving some antibiotics. For example, you're giving antibiotics that have spectrum on gram-negative, and also you just combine these antibiotics that have spectrum on gram-positive. But the point is that he doesn't know because he did not evaluate the patient. But what if it's not pneumonia at all? So he will be about to give antibiotics to patient that doesn't require antibiotics. So you're putting the patient at risk of developing antibiotic resistant, and that's not the case. So post-op breathlessness can be caused also by any other thing, because we don't know what kind of surgery that the patient had, but it can be caused by, I don't know, pulmonary hypertension, pulmonary emboli. It can be something related to the heart, anything, because breathlessness as a symptom is so broad. So you have to evaluate the patient, and he didn't do it. So it's so wrong, it's too vague, and too premature. Not acceptable at all.
Okay, she's full on lorazepam. She's had 4 milligrams. You cage Dr. Bailey and Dr. Shepard.
Lorazepam's not working.
All right, so the patient has recurrent seizures of unknown origin. So we don't really know what's going on and what causes these seizures. We think it's through the central nervous system, but since there is no diagnosis, there can be some genetic disorder that we are not aware of. What if some, for example, cardiac genetic disorder mimic seizures? Because the patient can have, for example, a channelopathy, meaning that there is some genetic mutation in the channels that are responsible for allowing ions to go in and out of myocytes in the heart. If they are mutated, it can induce seizures-like symptoms. But we don't know this. But anyway, let's say that this is because of central nervous system origin. So she was given benzodiazepines like our magic diazepam and lorazepam. They did not work. So let's see what they will do next.
Phenobarbital. Load her with phenobarbital.
Pheno's in.
No change.
Wait, what? What does it mean, no change? Like, obviously, there's no change. She was literally given phenobarbital intravenously, and what was she expecting? To see a result like instantaneously? No, it doesn't work this way. For phenobarbital to cross the blood-brain barrier, it takes several minutes, and then we can see some effect. But obviously, we didn't see it here. So no, it's actually a very bad recall. All right, so I'm trying to recall this ECG because, as we can see, she crashed. But I'm sorry, I can't, because whatever they shown to us, I don't know what it is. But anyway, so she crashed. And now the question is why she crashed. So she can have any cardiac arrest. It can be ventricular fibrillation, which is always shockable. It can be atrial fibrillation, which is also shockable in some situations. But she can also went into asystole, so there is no heartbeat whatsoever. So they should not use any defibrillator. They just start performing CPR. So obviously the point is to bring her back and then to perform any diagnosis to see what damage the cardiac arrest could cause to her, and finally to diagnose her.
Wait. Charge pounds to 200. Charge. Clear.
Still VFib, nothing.
Charging. 19 seconds. Charge to 300. 300. Anything? 27 seconds. Charge to 360. Come on, Katie. 49 seconds.
It's 60 seconds.
Did she just use one hand for CPR? Oh, I don't know.
Charge again. Anything? I see sinus rhythm.
Ooh, well done. Good job.
Pulse blood for your heart. Fix your ticker. Take you off the machine. I'm done. Simple procedure.
So, I shouldn't worry?
I'm very good at what I do. It still is surgery. There are some risks. I'll see you in the OR this afternoon, Mr. Savage. Okay.
I'm very good at what I'm doing. Yeah, we all see. But he mentioned about risks, but he never said what kind of risks. Like, he didn't say any important information to the patient. And that's quite bad, because when you're discussing this operation with a patient, you should tell about the pros, the cons, and the consequences of the operation and what can go wrong. Because the patient needs to know and needs to be aware of what can happen. The more complicated operation, the higher risk that something can go wrong. So he should have said what exactly can go wrong. And there is no explanation for hiding such informations. So
He'll be fine, right?
Tony's gonna sail through. You have nothing to worry about. Promise.
rule number 1, you don't promise something that you can't keep. And operations, you can't promise anything, because anything can go wrong.
I'm gonna ask interns for help. I've got this kid, Katie Bryce. Right now, she's a mystery. She doesn't respond to our meds. Her labs are clean, scans are pure.
All right, so we know that her bloods are clear. That's fine. But he also says scans are pure. But what kind of scans? If you have such mystical case, you should always be very clear at what you're saying. So you should always say what kind of scans did you perform and what you saw on their scans. And also, you should share these scans to other people, because probably you could potentially miss something. That's what you're supposed to do. You know, saying, oh, it's a mystery, it doesn't say anything. So, yeah, that's what you're supposed to do.
She has no headaches, no neck pain, her CT is clean. There's no medical proof of an aneurysm.
Right.
But what if she has an aneurysm anyway?
There are no indicators.
So she has no headache and no neck stiffness, and CT is clear for aneurysm, but CT is actually a not good tool for aneurysm, because what if it's a small aneurysm? You wouldn't see it. You'd only see aneurysm in CT if the aneurysm is quite big, or if the aneurysm is calcified. So you could actually miss any small aneurysm by just looking solely on CT scan. But you have other tools that you can use. For example, you have CT with contrast. You have cerebral angiography that you can use, and which is actually a gold standard to see if there is any aneurysm that could potentially rupture. So so that's the case. Also, he says there's no indication for aneurysm. What kind of indication? Like, they did not check, or at least they did not tell us, if there is any prior history that would assume that she could have congenital artery problems. So why there is no indication?
But she twisted her ankle a few weeks ago when she was practicing for the pageant.
Look, I appreciate you trying to help.
She fell. When she twisted her ankle, she fell.
Let's go. I'll be damned.
Here it is.
It's minute, but it's there. It's a subarachnoid hemorrhage.
There you go, subarachnoid hemorrhage. So that's the cause of seizures. If he had performed this cerebral angiography at the very beginning, we would have avoided all of this drama. But obviously, that's for purpose. But yeah, but that's the point. Usually, everything goes. You have to rule out everything step by step, and if you use all the opportunities, then you can just say that this is like a mystery, and you just need to consult this case with somebody else who is quite experienced in such things. That's what usually would happen. So that's the end of episode 1, season 1, Grey's Anatomy. It was quite nice experience trying to see the accuracy from the medical standpoint of view, because I was a huge fan of Grey's Anatomy like 20 odd years ago, and right now I can actually see why they create such drama, why they're exaggerating in many cases. Obviously, to keep people engaged in this TV series. So if you like it, thank you so much. If you didn't like something, just let me know. And what I'm trying to do, I will try to merge a few episodes into one clip to keep it shorter a little bit, because what I've noticed is that I just focus on the medical aspect in this first episode. I think that's not the case. So that's what I will do. And if you survive till the end, thank you so much, and see you next time.